talking about ophthalmic agents, which is chapter 10 in your book. First, we're going to redefine some terms and abbreviations, and then we will talk a little bit of review about anatomy of the eye. Box 10.1 is going to list some of the categories of agents used in ophthalmic surgery. A lot of times these will be on your sterile back table, so it's going to be really important that you guys properly identify and label all these medications when you receive them, especially when there's an operative microscope being used. So basically what this means is the surgeon a lot of times in eye surgery is going to be looking through a microscope because the structures of the eye are so small. So they're not going to want to keep looking up to verify what you're handing them to them. So it's important that you have them labeled, and then when you're handing it to the surgeon, let them know what you're handing them so they don't have to look up. A good way to understand ophthalmic agents is to do a little review of the anatomy of the eye. So you can see here, this is going to be the basic structure of everything that's in there. So the eye is going to be a complex sensory organ. It receives visual stimuli and then sends those signals to the brain to be interpreted. The eye also works with the help of a number of accessory structures like the eyebrows, eyelids, eyelashes, and lacrimal system. The eyebrows, eyelids, eyelashes, you can see that these all help to basically protect the eye. And then the lacrimal system is going to produce, distribute, and remove tears, which these are going to help keep the eye moist and clean. The conjunctiva lines the inside of the eyeballs and the globe. It's a thin, transparent mucous membrane. Its function is just to protect the eye. And you guys might be a little bit familiar with conjunctivitis. This is a relatively common eye disorder. If you think back to your midterm days, you'll remember itis means inflammation, so it's just an inflammation of the conjunctiva. So like the conjunctiva, the bony orbit is going to also protect the eye with the support of fat and fascia. And then the eye itself has 3 layers. They're going to be the fibrous layer, the vascular layer, and the nervous layer. The outer layer of the eye, or the sclera, this is the first part of the fibrous layer. It gives the globe of the eye its shape, and commonly you guys might know this better as the white of the eye. And then the limbus is the area where the cornea and sclera meet. Deep below the limbus is a venous sinus called the canal of Schlemm. And just like when we talk about anatomy in any of the other portions of the chapters, I just want this to be a review. You know, typically there's some questions, maybe general questions about anatomy, but nothing that's going to be super detailed. So please don't get stressed about this. The second part of the fibrous layer of the eye is the cornea. So the sclera is the white of the eye. That's going to be really important for you to remember. And then the cornea is the window of the eye. It doesn't contain any blood vessels, and instead it gets its nourishment and oxygen from a solution called the aqueous humor, and then it also gets oxygen from the air. The second layer of tissue in the eye's globe is vascular. So the vascular layer of the eye is called the choroid. The anterior and the thickest part is the ciliary body. It's important to remember your terms of anterior and posterior, if you remember these from anatomy. Anterior is always going to refer to the front, and posterior will refer to the back. So just keep that in mind. The ciliary body secretes aqueous humor from the ciliary processes, and then the ciliary muscles attaches to the eye lens, helping to accommodate near and far vision. The iris of the eye, this is between the cornea and the lens, and it's attached to the ciliary process. It works to change the size of its opening, and the opening within the iris is called the pupil. So, you know, you think most people are familiar with the iris of the eye. It is the colored portion. It's what you see. One of the first things you see when you're looking at a person's eyes, that color in their iris. The pupil controls how much light enters the eye by constricting or dilating. So it's not really a distinct structure, but rather it's an opening. And then lastly, the nervous inner layer of the eye is called the retina, and it's only present posteriorly. And we talked about a review of this posterior. Remember, that's going to be the back of the eye. It will only cover the choroid. And then the retina is going to have sensory receptors called rods and cones. These respond to images and send signals to the brain for recognition. The lens, another part of the eye, is just behind the iris. It's going to help focus images on the retina. Normally it will be transparent and it's covered by a clear fibrous capsule and held in place by suspensory ligaments called zonula. So the lens, if somebody has cataracts, this is what's going to become cloudy is the lens itself, and that's what we would go in and kind of suction out and replace with a brand new um, prosthetic lens in their eye. The interior portion of the globe has two cavities, anterior and posterior. They're separated by the lens, and then the anterior cavity itself is also divided into an anterior and posterior chamber as well. The anterior cavity contains the aqueous humor. Um, this will drain forward and then goes through the trabecular meshwork and into the canal of Schlemm. So any blockage in this meshwork causes intraocular pressure to build, leading to glaucoma. I think I can't remember if we've talked about glaucoma yet, but that's just increased pressure in the eye. I think we mentioned this on our diuretics chapter when we were kind of talking about glaucoma, but just remember that glaucoma is an increased pressure in the eye. The posterior cavity, which is between the lens and the retina, contains a thick substance called the vitreous humor. It's going to have a number of jobs, including giving the globe its shape, keeping the retina in place, and contributing to intraocular pressure. One thing also to keep in mind, the difference between vitreous humor and aqueous humor is vitreous humor is not going to be replaced. It can't be remade by the body. The anterior cavity is divided into two chambers, the anterior and posterior. Both chambers are filled with aqueous humor. The anterior chamber is posterior to the cornea and anterior to the iris. The posterior chamber, in contrast, is going to be posterior to the iris or behind it and anterior to the lens. And also, again, keep in mind that glaucoma is going to be the term used to describe a group of eye conditions that are characterized by an increased intraocular pressure. Now we're going to move on to actual ophthalmic agents. So this is going to be a lot more pertinent to surgery. We're going to kind of quickly cover these things. If you look at this figure, this kind of illustrates the proper administration of topical ophthalmic solutions and ointments. The first step in this is kind of a gentle retraction of the lower lid. And then after that, you'd place drops or ointment onto the lower cul-de-sac. Then you'd hold tight finger pressure over the lacrimal sac for about a minute. With the eye closed, you can kind of remove excess medication from the inner corner of the eyelid with the cotton ball. Medication-soaked pledgets can be placed in that cul-de-sac as well after the eye has been anesthetized with local. So that just means that the doctor would go ahead and numb the eye up, and then they could place these little pledgets. They're kind of like a little cotton material. You can see here they put them on a suture, and then they soak them into medication, and then they would actually be able to set those in that cul-de-sac to sit on the eye. So in surgery, anytime we're doing a procedure on any part of the body, we want to get it as clean as possible. So that is where ophthalmic prep solutions come in for eye procedures. The eyes are delicate, as you can remember from anatomy, so you want to make sure to use a special prep solution that isn't going to damage that area. So first thing you would do is prep that region, and you can see they've used a betadine solution here. And then afterwards, you're going to irrigate that with sterile saline solution. Here you can see a picture of a betadine 5% prep solution specifically made for the eye area. When you're doing a prep like this, you want to make sure to leave this in contact with the area for 2 minutes. This is going to be a sterile dark brown liquid. And again, when you're doing this on the patient, you're going to prep that region, let it sit for 2 minutes, and then irrigate it with a sterile saline solution. So next up, we're going to talk a little bit about irrigating solutions and lubricants. The purpose of irrigating solutions in ophthalmic procedures is to cleanse the operative site and keep the cornea moist. It's important to remember that the patient can't blink on their own a lot of times with these procedures because they typically will have what's called like a little eye retractor in there that holds their eye open so the surgeon can keep working. So they're not going to be able to blink to re-moisten the eye. So that's why it's important that we moisten that cornea for them. Also, lubricants can be used to protect the cornea when a patient is undergoing general anesthesia. Also, one thing to keep in mind, when you are wiping blood from the eye during an eye procedure, if the doctor has you do that at all, you don't want to use a gauze sponge. So when you're thinking about like a gauze square that you might use at home, you don't want to use anything like that on the eye because it can scratch the cornea. You'll want to use a special, what's called eye spear. It's very soft and it's not going to hurt the eye. The most common irrigating solution you guys are going to see is BSS, or balanced salt solution. It's sterile and it's physiologically balanced. It's made specifically for the eye. And you will also see lubricants like Lacrolube and Duratears that can be used. During most ophthalmic procedures, the surgical tech will be the one to use the BSS periodically to irrigate the cornea. This basically is just going to be a sterile little bottle. It's like a little tiny squeeze bottle that'll have a special tip on it, and you'll just periodically squeeze that to moisten the cornea for the doctor. And then lubricants, these are going to be, like we said, used on patients undergoing surgical procedures, not necessarily on the eye, but just under general anesthesia, and this is going to help protect the eye from any damage during surgery. Next up are viscoelastic agents. These are thick, jelly-like agents that are injected into that anterior chamber of the eye to help keep it expanded when doing cataract surgery. So when you're going in to break up that lens and everything, you just want everything to continue to have its natural shape. So this is what it's going to help with. It can also replace vitreous humor or serve as a tamponade. So when we're talking about bleeding, it can help apply that pressure to stop the bleeding. This slide is going to show you some examples of viscoelastic agents. They're going to be pre-measured in sterile syringes with blunt-tipped cannulas. Typically, they'll come in a box, and then you would open these, the inner package to the sterile field. The nice thing about these is you're just going to probably have to put that tip itself onto the syringe, like that little tip there. And the nice thing is they're already labeled, so you're probably not going to have to label anything. So now viscoelastic agents, they're not just considered medications to maintain that space and coat ocular tissues. With the way cataract surgery is performed these days, it's kind of a vital part of that with the new technique, so it's going to be really important. Next up, we're going to talk about miotics a little bit. Miotics are agents that constrict the pupil by stimulating the sphincter muscle of the iris. So it's important to remember the difference between miotics and mydriatics. A couple different ways you can do this. Miotics, you can think of little word equals little pupil, and mydriatics, big word equals big pupil. So when we're talking about constricting, remember that means to make smaller. Um, when we're using these, the pupil constriction does reduce intraocular pressure. So these are often used in short-term management of glaucoma. Here's some examples of miotics. Acetylcholine, pilocarpine, and carbachol would all fall under this category. Miotics are also used intraoperatively when pupillary constriction is indicated, like in a laser iridectomy. Also, after cataracts are removed, they can be used to help position that implant and hold it in place after that cataract is taken out. So kind of everything constricts down and holds that implanted lens where you want it to be. So we mentioned acetylcholine is a type of miotic. This is available in a solution of mannitol known as myocol E. So the mannitol with its diuretic effect facilitates drainage of the aqueous humor. So just keep that in mind, and then this is going to be something that is reconstituted or mixed immediately before it is used. Carbachol is a miotic used topically to reduce intraocular pressure in glaucoma and via injection into the anterior chamber during surgery. It can also help keep that intraocular lens in place. Pilocarpine acts directly on the smooth muscle of the iris to stimulate meiosis. This increases the flow of aqueous humor through the trabecular meshwork, so it's often used in treating open-angle glaucoma. Mydriatics and cycloplegics, these are both paralytic agents used to dilate the pupil before looking in the eye. They both cause pupil dilation by paralyzing the sphincter muscle of the iris. The one difference, though, is cycloplegics also paralyze the accommodating mechanism, which means patients will be possibly unable to clearly see objects that are close by. So again, I just want you to be familiar with the idea. Don't get caught up on, specifics of this one. Here are some common examples of these, atropine and phenylephrine. It's important to remember that these can cause side effects, including tachycardia, photophobia, dry mouth, edema, conjunctivitis, and dermatitis. In surgery, agents like these are mainly just used to provide access to the eye, just opening up that pupil so there's more area to work through. And again, just remember that you can either use the idea of little word, little pupil, or meiosis means to constrict. Both words have an O, and mydriasis both, means to dilate. Both have an A or both have a D. So whichever one of those works better to help you remember. I typically like the little word, little pupil better, but however you can remember best is what works for you. Next category of agents are ophthalmic anti-infectives. So these in ointment form are often used to treat external ocular infections. Some of the common ones are going to be gentamicin, neosporin, Vigamox, Zymar, and Siloxane. In surgery, a lot of times these anti-infectives are used to guard against postoperative infections. A unique category of the ophthalmic agents are anesthetics. These are unique because they interfere with normal transmission of pain impulses to the brain. Most ophthalmic surgical procedures are going to require a topical and injected anesthetic agent. So two common options are going to be tetracaine hydrochloride and proparacaine hydrochloride. These are both available in a 0.5% ophthalmic solution. So again, these are going to interfere with pain impulses either topically, which means, maybe an eye drop, something in that form, or by injection. The final category of ophthalmic agents are anti-glaucoma agents. We've mentioned a couple times now, glaucoma is going to refer to a group of conditions that are characterized by increased intraocular pressure. This can be caused by an overproduction of the aqueous humor or by a blockage in the drainage mechanism. So as their name suggests, anti-glaucoma agents work to decrease that pressure. There are several subcategories in this category. There's miotics, beta adrenergic blockers, diuretics, alpha adrenergic agonists, and prostaglandin analogs. As far as miotics, you can look at the other slides to kind of review that if you want, but these are just usually a short-term treatment option. Osmotic diuretics are another class of these anti-glaucoma agents. They can be used to treat glaucoma in the short term by raising the osmotic pressure of the blood, which just means the fluid is being drawn out of the eye, and then in turn it lowers that pressure. Alpha adrenergic agonists, these are administered as eye drops, and you can see some different examples here. Beta adrenergic blockers block beta adrenergic receptor sites. So these drugs, and you can see some of them listed here, they help treat glaucoma by reducing aqueous fluid production. So if the eye isn't producing so much fluid, then that's going to decrease the pressure. Also, side effects of these agents include decreased heart rate and blood pressure. Glaucoma may be managed in the long term with different kinds of diuretics, particularly carbonic anhydrase inhibitors. These interfere with production of carbonic anhydrase, which also reduces aqueous humor production and decreases intraocular pressure. These can be given orally or by IV. Side effects will include lethargy, anorexia, drowsiness, nausea, vomiting, and hypokalemia. PGAs, or prostaglandin analogs, these are now going to be the first line of medical treatment for glaucoma. They significantly reduce intraocular pressure by increasing outflow through a different route than that trabecular meshwork. Of these agents, only mannitol will be given during surgery. If you want to review, you can think back to that diuretics chapter, but this works in the same way, and it's just going to be mainly important when a doctor is trying to do retinal work. Two categories of anti-inflammatory agents are used in ophthalmology, steroids and NSAIDs. The general purpose of these is just to reduce inflammation and swelling postoperatively. So anytime you are manipulating the eye, it's going to cause inflammation naturally, so these are going to kind of help to counteract that. The first class of anti-inflammatory agents, which is steroids, some of these are shown here. These are hormones with a wide range of effects. They can be used in ophthalmology to decrease ocular inflammatory response to trauma, decrease corneal inflammation, and protect the eye from scarring. Postoperatively, they are used to decrease swelling. Big thing to keep in mind with this is they are contraindicated in the presence of infection. So with these, they're not bactericidal. They don't kill off bacteria. and they do tend to hide symptoms of an infection. So if somebody is on these anti-inflammatory agents and has an infection, then it's not going to show them the symptoms as well, and it's not going to go diagnosed. This slide provides some examples of the second class of anti-inflammatory agents, or NSAIDs. You guys have probably heard of NSAIDs. They're non-steroidal anti-inflammatory drugs. NSAIDs are going to be used to prevent or treat cystoid macular edema, iriditis, and conjunctivitis. They're also used to prevent post-op inflammation after cataract surgery and possibly to inhibit intraoperative meiosis. The final class of ophthalmic agents are the diagnostic stains. Several agents are available for diagnostic uses. Most used in surgery are going to be dyes, and remember that dyes are used to color or mark tissue. Here's some examples of diagnostic stains. Ophthalmic dyes are instilled topically to diagnose abnormalities of the cornea and the conjunctival epithelium, or to also locate foreign bodies in the eye. Dyes may also be used to observe the flow of the aqueous humor or to demonstrate lacrimal system function. In surgery, fluorescein sodium is a non-toxic water-soluble dye that's applied to the cornea and the conjunctiva to identify areas of epithelium that maybe have had damage to them, or also to locate foreign bodies. It's going to diagnose corneal abrasions by staining them bright green. So you can kind of see on the slide here where it has the bright green for that corneal abrasion on that bottom kind of left. And then rose bengal is even better at staining for these devitalized cells. It's going to be used mostly to kind of show devitalized conjunctival epithelium in dry eye syndrome. So that's going to be more of an office use only. Lissamine green is very similar to rose bengal. It's going to be used in the office to diagnose dry eye. Indocyanine green is going to be a diagnostic dye used in ophthalmic angiography. It's given through an IV, and this is done outside surgery to visualize the choroidal vascular network. So, it's just important that you guys know the drugs you're handling, their categories and purposes. Um, the ophthalmic area of surgery is going to be a little more limited. You may find yourself at a surgery center where all they do is eye procedures. Some of the smaller outpatient places will do more cataract work and that kind of thing as well. And then there's some hospitals you're not going to see eye surgery at all. So just know you may or may not see these things, but it's important to have the background knowledge before you get there so you know what you are handling. So a little bit with the advanced practices. Approximately 20.5 million Americans have cataracts interfering with their vision. So by the age of 80, more than half of all Americans will have cataracts. So the cataract extraction is an intraocular procedure. Most commonly in the US, they're going to use what's called extracapsular extraction of these cataracts with phacoemulsification. It's where they use like a little handpiece basically to break up that cataract and then suction it out. And then after they do that, they will put in a lens implant to replace that lens that they took out, and it'll stay in place. If you look at this, the top intercapsular, that means the lens is completely removed. There's going to be no lens. Extracapsular means the back of the capsule is left, and then you implant an intraocular lens. And like we said, this is the typical method that's done here. It's going to be important that the patient is given the proper preoperative medications just for their safety. And then also after surgery, it's going to involve getting certain kind of drops afterwards. When we're talking about local anesthesia in the eye, so a topical method where they actually will do drops, this has increased in popularity for cataract extraction. It's going to help to numb up the eye. During the cataract surgery, intraoperatively, a lot of times it will include BSS or BSS plus, and you'll remember that is an irrigating solution. Some doctors also like to add an antibiotic to this, just kind of it's an extra form of protection. And then postoperatively, a patient's a lot of times going to be released pretty quickly after surgery, within a couple of hours. If a patient has experienced nausea in the past, or it does before they leave, they can also give them some Zofran before discharge, which is going to help with that nausea and vomiting. Some surgeons do like to put patches over the eye and a shield so the patient can't rub their eye, and that's going to be another form of protection, so they might go home with an eye patch like that. The patient will be instructed to avoid activities that can increase the pressure in the eye. And then normally the patient's going to be seen the next day after surgery just for an evaluation to check and make sure their pressures are normal and there's nothing bad going on with their eye. So hopefully that was helpful and you found some of that interesting. Like I said, this chapter is a little bit more limited in use because some of you are never going to see these agents if you don't work someplace that does eye procedures. But some of you, this could be what you're doing day in, day out. So it's just important to know the background. So hope you have a great day. Bye.